Okay, can you see my slides?
Yes.
All right, great. So just to tell you brief about me is, yes, I'm a diabetologist. I'm an adult endocrinologist at the Barbara Davis Center for Diabetes. So I do everything about type 1 diabetes with interest in a bone. So it's kind of other way around. And here are my disclosure, and the only the grants from the NIH are probably relevant to this presentation. Otherwise, most of the industry's research funding and other things are, my another research is involved in a clinical trials of diabetes technologies in type 1 diabetes. So I do a lot of clinical trials in CGM, hybrid closed loop system. People call it an artificial pancreas system. So those industry fundings listed here are more relevant to that life that I live in this research area. What I'm going to talk today briefly is that I will just talk about the historical perspective, and this is more relevant in a context like why suddenly we all are interested in bone health in diabetes, despite that diabetes is a disease for that we know for many years. What is the data on a fracture risk in type 1 diabetes, and some brief discussion on the bone structural quality and tissue material qualities in type 1 diabetes. And again, my talk is entirely focused on type 1 diabetes. So you won't see much studies or data about type 2 diabetes, but I'll be happy to discuss that if you have any questions around that part. And then briefly, I will talk about my two NIH-funded studies, and I'll be happy to get your inputs, feedback on those studies. So when I started reviewing the literature when I was a fellow 12 years back, I came across this article, very beautiful article, was published in American Journal of Medical Science in 1927. Definitely, I was not born at the time, and probably many of us are not. So think about that. This was published way back. They looked at the X-ray. This was in hand because DEXA was not available at the time. Hand X-ray of children with diabetes, and at the time they used to call diabetic children, but nowadays we don't use the term diabetic. It's not considered as an appropriate term. So in children with diabetes, and interestingly, they found that higher prevalence of an osteopenia looking at the hand X-rays in children with diabetes. And this is not available online. So I had to go to the library and find that out. And those pages are turned yellow. So you can see that it's not like a great image here. But after that, I think there was no buzz about the bone and diabetes. And there are reasons for that, of course. So this is kind of my visualization about the change in the diabetes care in the landscape. So in a y-axis, I just kind of like hypothetically plot that a longevity. And on an x-axis, I will just show you the change in the diabetes landscape. And this is the time, 100th year anniversary of an insulin discovery by Banting and Best. I'm sure many of you know this picture very well. And the dog's name in this picture is Marjorie, but many of us don't know that part. But anyway, just the side effect. Facts. So after 1921, when insulin was discovered, the best thing happened in diabetes care is that there was a reduction in the acute diabetes complication, particularly DKA. Before insulin discovery, hardly people used to live beyond 30th year of their life. So pretty much the diabetes was like, okay, everybody will die, before 1921 by their second or third decade of life. And insulin has changed that significantly. But with that insulin discovery, then researchers focused on purifying insulin because, again, remember that insulin was not the best at the time. It was an animal-derived insulin. So purification, then changing the insulin structure, recombinant DNA technology made a lot of changes into that. We now have a human insulins and recombinant DNA insulin analogs available. So about 50 years after insulin discovery, we spent a time in making insulin better for us, right? And then, of course, this was a landmark DCCT DCCT clinical trial. That's a diabetes complication and control trial. that provided us much needed evidence that if you try to improve glycemic control, that's an A1C, and if your A1C is 7% or below, then there would be a 40 to 60% reduction in the microvascular complications. Now, microvascular complications are namely the eye complication, kidney complication, and neuropathy, right? So retinopathy, nephropathy, and neuropathy. And then all the guidelines changed, and then we became an really A1C centric. We really focused on improving glycemic control. Thanks to that, now we see that less people with type 1 diabetes have a microvascular complication. They are living longer. And now we are entering into the era of an really a tech era, I call it, because most of my patients nowadays are on a continuous glucose monitor. So you slap a device on your skin and it measures your glucose every 5 minutes. You don't have to poke your finger at all. Now, also people are using insulin pump that delivers you insulin. And now you can engineering or mathematical algorithm, you can use that and you can make it an artificial pancreas. And there are already 2 systems available in the US market. That's a Medtronic 670G, Tandem Control IQ, and many more are coming. So the landscape has changed, and because of that, people are living longer. And for researchers, it made us realize that now we need to focus slightly different. Moving from that insulin, moving from microvascular complication to the macrovascular complication like cardiovascular health, or the issues related to the aging, like dementia in people with diabetes, and of course, the fracture risk in people with diabetes. And therefore, I think there is a resurgence of interest by a lot of researchers in this area. And just before this talk, I just Googled about diabetes and bone, and surprisingly, but not surprisingly, 10,000 articles have been published in PubMed till date. And out of that, 90%, more than 9,000 articles are just published in last 20 years. So think about that. Before that, we were not much focused on understanding how diabetes would affect the bone health. And again, there are reasons for that, as I mentioned earlier. Also, the ASBMR, for last 3 consecutive years, I'm listening webinar, at least have one topic on diabetes and bone, and this was in 2020 and 2021. So this is a second bone in type 1 in 2021. Okay, I'm gonna switch a gear and talk about the fracture risk in type 1 diabetes, and probably you guys are aware about the literature very well. But when we published our first meta-analysis of fracture risk in type 1 diabetes, not surprising, but it was really eye-opening that fracture risk in people with type 1 diabetes, and if you think about major osteoporotic fracture, that's a hip spine distal radius, it was 3 times higher. And if you think about the hip fracture, it was about 4 times higher in people with type 1 diabetes compared to people without diabetes. A lot of people ask me that the spine fracture risk was lower in our meta-analysis. That means that diabetes is affecting more hip than spine. The answer is no. And the answer is that spine fractures are asymptomatic. So in the studies, spine fractures are less reported than the hip fractures because hip fracture would require hospitalization. So this is kind of a bias of including those spine fractures unless you do an X-ray in studies for everybody. After that meta-analysis, we just wanted to look at our own population that we are caring in for diabetes in a clinic as well as in a research. And see whether we can replicate our findings. So this is a CACTI study. So for you guys, if you don't know, it's a coronary artery calcification in type 1 study. 700 type 1 patients and 700 controls were recruited 16 years back. Their mean age was 30 years and they are followed for about 16 years now, and they are still following that cohort. Generally to look at like cardiovascular risk in people with type 1 diabetes, but I just had an opportunity to interact with this CACTI cohort, and we asked a questionnaire and just looked at people who are interested in bone health, and 203 people with type 1 diabetes responded, and 286 people without diabetes responded to a survey. It was really one-page survey, and we just asked about their bone health. Again, self-reporting, take that with a pinch of salt, not a great study, but we found out that the people with type 1 diabetes had about 2.5-fold higher risk of fracture. So it's almost similar as like a meta-analysis. And we also looked at the US National Registry of Type 1 Diabetes. So there are 70 plus centers are partnering in this registry, and they share their electronic medical based data or record. And there are 30,000 people with type 1 diabetes registered in this T1D Exchange Clinical Registry. Again, very low response rate. So what we did is that we just sent out one email short questionnaire to adults with type 1 diabetes in the registry. 756 adults responded with a mean age of 39 years. Majority of the responders were female with the diabetes duration of about 24 years. We included only fracture that happened after type 1 diabetes diagnosis. So let's say, for example, if someone diagnosed at the age of 18 years but had a fracture before 18 years, then we did not include that in this study. And despite those kind of stringent criteria, 48% reported at least one fracture. Of course, the fractures of lower extremities were very common. 12% had a major osteoporotic fractures. And interestingly, type 1 diabetes diagnosis prior to the age 20 was one of the risk factor in this. Now, again, take this with a pinch of salt because it's only type 1 diabetes population. It's a registry-based data. There was no control group and it's a cross-sectional, right? And it's likely that people have a more problem are going to take part in this kind of survey. So therefore, probably you see probably higher rate of fractures here as well. Anyway, another study from UK, very nice study published in JBMR 2014, and looked at the hip fracture crude rate of a hip fracture. Now, hip fractures requires hospitalization, so this is the easiest and most accurate way of getting an information from the medical record. And what they found is that you can see this gray line. These are the women with type 1 diabetes had a really high fracture risk compared to women without diabetes, that is in a yellow line, at any given age, starting from the age 40 years. But statistically, that separation happens at the age 50 years. But to me, interesting part was not just that part, but the blue line, that's the man with type 1 diabetes, had a higher fracture risk compared to even women without diabetes. So if the man has diabetes, the fracture risk is way higher than a postmenopausal female who do not have diabetes. So it's very striking. And similar findings have been reported by David Weber in Diabetes Care in 2015. And he used the same UK database from a thin registry. So not surprised that the data looks similar than previous publication. So in a nutshell, from these studies, you can definitely say that the fracture risk is higher in people with type 1 diabetes, and the fracture risk is happening at the younger age than we can think of. So there is a problem. Now, what could be the reasons for high fracture risk? You can have a problem with the bone density, or you can have a problem with the bone quality. And the last thing is that even though everything is normal, but if you keep falling, you're going to fracture, right? So if there is a problem with the falls, then it can also cause fracture. So what about the bone density? We looked at the bone density across the lifespan in patients with type 1 diabetes. We had 194 patients with type 1 diabetes from age 5 to 71 years. Matched controls. We selected controls very well from 3 ongoing studies. Everybody had a lumbar spine BMD done from a same machine, same instrument. So we had a good way of comparing their baseline BMD across the lifespan. And we didn't find any clinically meaningful differences across the age. Of course, the postmenopausal women with type 1 diabetes had a slightly lower BMD compared to postmenopausal women without diabetes. But other than that, we did not find any difference. And similarly, when we published our meta-analysis, again, we did not find really meaningful differences between type 1 diabetes and control groups. The difference at the spine was, if I remember correctly, was 0.05 gram per centimeter square. And again, not a huge. It was a statistically significant at femoral neck, but again, to me, clinically not that significant. Now, these are our studies, but there are other studies that reported BMD, which is lower in patients with type 1 diabetes. And you might wonder that why there is so much of a discrepancy in literature about the bone health in type 1 diabetes. And this is true in type 2 diabetes as well. And I'm going to go back to my slide, and I will just give you a my perspective why there is so much of a heterogeneity. So let's say think about that, and this is again a scale of diabetes care, and the diabetes care is moving in a right direction. Now if you do a study somewhere in 2000 and you enroll the participants who have diabetes for a long time, about 20-30 years, at this point of a time, the patient's bone health is actually a reflective of the last 20-30 years of diabetes care, right? Versus, let's say now I'm investigating bone health here somewhere, and now that will reflect the diabetes care of last 20-30 years. So the diabetes care is moving. So it's quite possible that your findings, that what you're gonna probably look at is also gonna be moving. And a lot of different studies would have a discrepancy in their finding because of this reason. And this is one of the reasons, I would say, but happy to discuss that more if you have questions around that part. Now, what about the structural bone quality? And you can look at the structure either by a trabecular bone score, very simple tool, which is integrated in the DEXA. You don't have to do anything separately. It automatically calculates the trabecular bone score from the DEXA spine image. Or you can do a QCT, which is an axial CT scan of your hip and spine, or the peripheral QCT or HRP QCT, where you can look at the distal radius, distal tibia, and look at the bone structure. We looked at the trabecular bone score in one of our studies, even though it was a statistical difference between patients with type 1 diabetes and control, but everybody had a normal TBS score in our study. So to me, again, even though we find a statistical difference, it's not a clinically meaningful difference. And there was another study published by another group. They found that the people with type 1 diabetes had a lower trabecular bone score compared to people without diabetes. And again, as I mentioned earlier, that the discrepancy in the findings is because of that, different population and different type of diabetes cares that they have received probably over the last 20-30 years. What about the QCT? I'm aware about only one study from Japan, very small study. They recruited 17 men with type 1, 18 men without diabetes. So pretty small sample size, and they found that the total volumetric BMD and the cortical thickness at the femoral neck was lower in patients with type 1 diabetes compared to control. But again, one study does not mean much to all of us. Again, HRPQ-CT, I'm not going to go into the details of these studies, and I just showed you one study that kind of like, represents some key findings that are being replicated by other studies as well. In this study, what they found is that they had 55 adults with type 1 diabetes and 55 age, sex, and BMI frequency matched controls. And there was no difference in fracture rates or the aerial BMD by DEXA between two groups. And people with type 1 diabetes, so this is a cartoon here on my right side. And you can see here that on top line, it's the control group. So the figure here is a cross-sectional. This is a three-dimensional. B is the trabecular and C is the cortical thickness. So control group, that's as we consider that as okay, normal in terms of bone structural quality. The people with type 1 diabetes, but who do not have a microvascular disease, had a slightly lower trabecular bone quality, but statistically not different from control group. Again, slightly thinner cortices, but again, statistically not that different from control group. But people with type 1 diabetes who have microvascular disease, which is the lowest panel, then they had really more structural deterioration in both trabecular bone as well as the cortical bone. They had thinner cortices, they had a more cortical porosity, and lower trabecular volumetric BMD at the distal radius. We did distal radius PQCT in 24 postmenopausal women with type 1 and 22 frequency matched control without diabetes. Their mean age was 60, though control group was 3 years older than the type 1 diabetes group. Look at type 1 diabetes duration, 40 years of diabetes. That's pretty long standing diabetes. Their A1C was 7.7 at the time of the enrollment. No, not really any difference in terms of any baseline characteristic between two groups. That includes even the bone turnover markers, and the intake of their dietary calcium or urinary calcium excretion. Everything was pretty much the same between two groups. And we looked at their distal radius, and this is just an image to explain you that we looked at the distal radius at the 4% and 33%. That's for the cortical site, and similarly for tibia. And again, we did not find much difference between two groups, except that trabecular volumetric BMD at the distal radius was lower in patients with type 1 diabetes compared to the control group. However, when we separated patients with type 1 diabetes into two subgroups, one group is that the patients with type 1 diabetes who are diagnosed before the age 20 years. And the another group is that they are diagnosed during the adult onset, or we call it adult onset type 1 diabetes. And now there is a misconception that people with type 1 diabetes, that means type 1 diabetes, are generally diagnosed in kids, but that's not true. 50% of type 1 diabetes are actually adult onset type 1 diabetes. And then we compared these two groups, that's a young onset and adult onset type 1 diabetes, then we found everything was different. Trabecular volumetric BMD, cortical volumetric BMD was reduced in young onset compared to the adult onset. And interestingly, the endosteal circumference was reduced with a similar periosteal. That means the cortical thickness was reduced in young onset type 1, but not in adult onset. So from that study, we kind of hypothesized that it's quite possible that the people with type 1 diabetes who are diagnosed before their bone accrual, and we know that 90% of bone accrual happens by 20 years of age, more than 90%, I would say. Then probably that glycemic control, the diabetes during that time might be influencing their bone health. And therefore, young onset is probably more detrimental than the adult onset diabetes. So this may be one of the variables that why different studies are reporting different findings. Okay, what about tissue material qualities? Now you guys all know that the hyperglycemia is a main factor for an advanced glycation end products, which is a non-enzymatic glycation of collagen that leads to brittle bone. I'm not going to go into the details about that part, but there are a number of studies, mostly in type 2 diabetes population. There was only one study by Bob Recker group from Nebraska in type 1, again, a very small sample size, but everyone is telling the same story, that there is a clear link between the AGE in the bone or AGE in the serum, which is a pentosidine measured mostly in studies, and the fracture risk, or the tissue material properties measured in vitro. So summarizing that background of all these different studies is that fracture risk is about 3 to 4-fold higher in people with type 1 diabetes than peers without diabetes. DEXA BMD doesn't make much sense. It doesn't explain a fracture risk in these people. The PQCTs, PQCT studies, great studies. They does provide us some insight that the bone quality may be compromised in patients with type 1 diabetes, but they don't provide you really much details about the hip. And that's our main area of interest, because hip fractures are the ones that increases the mortality in both type 1 and type 2. There is a link between AGE and bone brittleness, but again, there is no clarity around that part. And when I say no clarity, that means that we really don't understand that the relationship between the AGE deposited in the bone versus the AGE that we are measuring in the serum. And also, to my mind, is that doing a bone biopsy, it's not a viable option for large longitudinal studies. So we need to find something that we can measure the AGEs from a peripheral site, and we can probably test that in a longitudinal studies. All right, so now very briefly, I will touch on my ongoing studies, and happy to get your feedback after that. So this study was a career development grant funded by the NIAMS. This is in a third year going on. So we recruited 30 postmenopausal women with type 1 diabetes of at least 10 years duration. Type 1 diabetes, very strict criteria, age greater than 40 years, and 30 age, sex, and BMI matched healthy controls of, again, postmenopausal women, but without diabetes. And we had a strict criteria, HbA1c of less than 5.7 to be in the study. It's a cross-sectional, so we have tried to obtain their 10 years of A1C from a medical record, and so we can get their 10 years of background glycemic control story. Then we're going to have a questionnaires to understand their diet, physical activity, diabetes complication, management, everything that we can think of. Fall risk assessment, hand grip, and we're going to do a bunch of blood and urine collection to measure bone turnover, different things that, again, we do that in studies. And the imaging is the QCT of hip, where we will look at the volumetric BMD cross-sectional properties and the finite element-based strength. The subset of that patient would be invited for the second visit. And this part is very interesting to me. And really interested in this section is what we are doing is that 1 month prior to the bone biopsy. So we're going to do a bone biopsy in that subsection of the patients. But before bone biopsy, we're going to put them on a continuous glucose monitor so that we can have the 24/7 glucose information at least a few weeks prior to their bone biopsy. And we're going to, of course, give them a tetracycline to label bone. And we're going to look at, of course, number one is the histology. And the idea there is trying to correlate the acute fluctuations in the glucose over a few weeks period of time in relation with the bone turnover in histology or histomorphometry. And then other metrics that we're going to look at is mostly the tissue material properties, which are mineral to metric ratio, mineral volume fraction, and the nano indentation for the elasticity and the hardness. So that's a very broad overview of the K grant, and the fortunate to receive the NIDDK R01. In this R01, we're gonna prospectively follow 113 type 1 and 113 type with healthy controls without diabetes, and we will follow them every year for a consecutive 3 years. And the year one, we're going to do their skeletal phenotyping by DEXA, QCT, and then finite element-based strength analysis. And we are doing QCT of both spine and hip. We intend to do actually BMSI, that's a bone material strength index by the osteoprobe. If you guys are aware that it's a small handheld device that you just prick that on a tibial bone, and it measures the strength there. Anyway, but the company didn't get the FDA IDE certification, so we could not obtain that device, and unfortunately we have to drop that from our R01 now. But we are also collecting their blood sample, urine sample, questionnaires, everything that we can think of: diet, physical activity, diabetes related complications. We are collecting those information. But the two interesting things that we are doing in this study is that one is the continuous glucose monitor. So I'm putting a continuous glucose monitor every visit, and plus the people who are using their own continuous glucose monitor, we are collecting that information as well. So we're gonna get their real long-term glycemic control by A1C, glycemic control by continuous glucose monitor, and the glucose variability by the continuous glucose monitors. And we are also looking at the AGE in the skin. So as I mentioned earlier, that the AGE from a bone, it's not viable for longitudinal large epidemiology studies. So we are trying to correlate the AGE from a skin, from blood, and then we will try to correlate those metrics with the bone material testing and see if we can probably use the skin AGE as a surrogate marker. But again, that's a hypothesis. So over 3 years, we will probably try to understand the rate of change in the bone mineral density and the bone structural properties between type 1 and control, and what factors are affecting that. So that's in a nutshell, kind of a very broad 30,000 feet overview about this R01, but happy to take any questions you guys have. And lastly, nothing is possible without a big team and good funding, right? So thanks to NIH, thanks to T1D Exchange, other contributors who funded some of my wild ideas. And thanks to everyone in my team here at the Barbara Davis Center and the Colorado University of Colorado Anschutz campus and outside the campus to really help me in understanding some of the things about how diabetes is affecting the bone health. So thanks, I will stop here. I think I may have taken probably 5 more minutes. Sorry for that. I think there are a few things in the chat. Okay. Oh, it's in general chat and no questions.
Thank you, Dr. Shah. That was great. Again, like you said, I'd like to open it up for questions, comments now. And it does look like our second presenter was unable to join, so please feel free to take.
Oh, okay. I would have probably taken more time, but anyway.
Anything you'd like to revisit, feel free.
Can I ask a question?
Go ahead. Sure. Go ahead.
Yeah, well, thank you for the very nice presentation. Very interesting. I found quite interesting when you highlighted the difference in bone health, what your findings related to the onset of diabetes, because I think that it's a very interesting thing, like the peak of bone mass accrual and if the disease is before and after. Did you have any information about the control, like how these people were controlled, like during this, this peak of bone mass accrual, this like diabetes around the 20s, or it was just a one-off thing? Like if they had diabetes on that period, it was already enough to kind of have some influence? Or I know that this is very hard data to collect, no, because like we are doing it retrospectively, and as you mentioned, and I find it very interesting that like the care has been changing. So how a well-controlled diabetes has been changing. So it's very hard to know exactly what went on, but like what kind of information do you have?
Great question, and thanks for that question. So it was a cross-sectional way of looking at the bone mineral density across the lifespan, right? And also in the second study that you are mentioning about is that just the cross-sectional way of looking at the bone structural by PQCT at the distal radius between postmenopausal women and women without diabetes. We did not really have their long-term information. Now, these people had diabetes for 40 years, right? Now, the 40 years was the mean, but when you try to divide that group into young onset type 1 diabetes, they had a diabetes duration of 50 years compared to the adult onset diabetes, where their diabetes duration was about 40 years. So now if you go back to my chart, that means those people were not on a great probably diabetes care, right? And again, it's really hard for any of us to really collect the information that what might have happened during that time while they're accruing their bone. But at least I can tell one thing is that, if you think about 4 years back, this was the time of the DCCT. We were still trying to understand that what should be the normal A1C to reduce the microvascular complication, right? And so I think a lot of people were on older insulin, their mean A1C were higher. I think this finding may probably, become irrelevant after 20, 30 years, but great question. I think that those factors do influence the bone accrual, but I don't know. This is just my kind of an hypothesis.
Was there anything any association with microvascular complications in this population? Because some people, they have diabetes for a long time and they don't really have like microvascular complications. So right. How was it in your survey?
All 24 patients in our cohort had microvascular complication. Okay. So for us, it was hard to separate, like, okay, people with microvascular, no microvascular, but everybody had complications. So, okay, but despite that, if you look at overall differences between two groups, that's type 1 and the control group, we did not find any statistical difference between overall their total volumetric BMD, except at the trabecular site. So despite 40 years of diabetes, despite microvascular complications in everyone, I think they were relatively doing okay in my mind, right? So again, I'm going back to the same, circling to the same thing, is that things have changed so much drastically in diabetes care that now we are seeing that kind of an effect over time. But again, I think I don't know anything about how diabetes influences the bone health. So these are just my hypotheses.
Just a bit more.
Yeah, sure. Go ahead. I think we have time.
About cortical porosity, like it's one of the main structural findings in microarchitecture. So and you were talking more about trabecular findings. So do you have any, did you find anything?
Again, great question. Again, we use the PQCT, right? So PQCT do not provide you any information about the cortical porosity. So my institution did not have an HR PQCT before. Now we got an SIG grant funded, which will bring the HRPQCT, and hopefully we'll get it installed by the end of this year. So look forward to that, use that instrument and get more details about the cortical porosity, what happens, in terms of cortical porosity over time. But one thing is that, think about that in aging, the major part of the aging is that increase in cortical porosity. And this is in generally osteoporosis in people without diabetes, right? And with the aging, you also have increase in AGE. These people with diabetes, I think they have more AGE and some kind of a premature aging because of more AGEs would definitely lead to more cortical porosity. So I wouldn't surprise if I do, and let's say a study of an HRPQCT and I find a more cortical porosity. I think I wouldn't be surprised by that.
Maybe a naive question, because I don't usually study the diabetes, and this is probably a little outside of your presentation, but I've always been kind of fascinated in the discrepancy between the fact that both type 1 and type 2 have increased fracture risk, but type 1 tends to have relatively normal or low bone mass, and type 2 tends to have higher. Is it all related to glycemic control, or does that imply that there's something unique about those two disease situations that contribute?
Okay, great. That's a separate talk. I'm gonna try that in probably a minute or two.
Well, I figured I had you here, so I give the question to try.
No, it's a great question, and I think what annoys me in a literature is that people in the title just write diabetes. Okay, diabetes is like a broad umbrella term. Okay, there is a type 1, there is type 2, there is a monogenic diabetes, there is a mitochondrial diabetes, there are so many pancreatic diabetes, right? And we don't know anything about what happens to the bone health in people who have a monogenic diabetes or people who have a pancreatic diabetes. What we are talking about is only type 1 and type 2 right now. So anyway, great question. So the basic differences are in type 1 and type 2 is the pathophysiology. That's number one. People with type 1 diabetes are diagnosed slightly in an earlier age than people with type 2 diabetes. That's number one. Number two is that the pathophysiology of type 1 diabetes is an autoimmune destruction of a beta cells leading to insulin deficiency. So these people require insulin from day one. Versus in a type 2 diabetes, you have a high risk genes that makes you insulin resistance. You are overweight to begin with, and then over 10 to 15 years of time, your beta cells are quitting because they are overworking for the 10 to 15 years. So if you measure the endogenous insulin secretion in people who have number one, obesity, but no diabetes, pre-diabetes, and obesity, then the insulin levels are far higher than people without diabetes. Insulin is going to increase the IGF-1 concentration. IGF-1 would improve your bone, at least the density. I don't know much about other aspect of the quality. And the weight itself would lead to more BMD because the weight, the bone, one way he is responding is the gravity and weight, right? So I think the difference in the pathophysiology, age of onset, the insulin dependence versus independence, in my mind is one of the major factor for you see more BMD in people with type 2 and probably normal or low BMD in people with type 1. Does that make sense?
Yeah, I think so. Is there a contribution to inflammation in either of those, though? And I suspect there's.
Great point, and I think that's an area understudied. Both types. So there are some common things between type 1 and type 2. One of the common things is the hyperglycemia, and the second common thing is actually inflammation and insulin resistance. Traditionally, people used to believe that type 1 diabetes are kind of a less insulin resistance than type 2 diabetes, but that's not true anymore. There are a lot of new studies are refuting that kind of a claim, right? So I think you are absolutely right. That's a common between type 1 and type 2, and I don't know really the contribution of that. But great point, yeah.
Thanks.
Mm-hmm.
So in your study where you looked at the type 1 and you looked at bone mineral density, you didn't see a difference between control and the diabetic population. Do you know anything about, was the BMI of these individuals average or normal BMI, or were they similar to what you would see with the type 2?
Again, good question. So the BMI was similar between type 1 and control in our study. Okay, so number one is that variable didn't play much role there. if you ask me about the BMI overall in type 1 diabetes population in the past, and again, I'm saying that diabetes care is kind of evolving over time, the people with type 1 diabetes are generally so-called lower BMI or normal BMI. People with type 2 used to be higher BMI, but not anymore. If you look at the BMI, mean BMI in a T1D exchange registry, it's at 27.8. So if the mean BMI is 27 in type 1 diabetes population, they are becoming pretty much similar as type 2 in terms of their weight. And that will complicate the future studies, right?
It does look like there's a question in the chat too from Ling Quinn, and you may have already touched on this, but she asked, do you think the treatment for type 1 diabetes patients could have any effects on bone quality?
I think so. Again, when I say I think, that's my kind of an hypothesis because there is no evidence to cite that. Number one is if you really have a good glycemic control to begin with when you are developed with type 1 diabetes, particularly at the young age, I do believe that it should help you on a long run to have a lower compromised bone quality, because you will probably have a less disruption in your bone accrual. But that's totally my hypothesis. And we are testing a part of that hypothesis in our R01, because we are we are aiming to have a 50% of our type 1 population to be young onset versus 50% is like an adult onset type 1 diabetes, so that we can try to differentiate some of those hypotheses, try to evaluate some of those hypotheses. But yeah, I kind of agree, but that's again my thinking, not an evidence-based. These are great point to probably study those things. Happy to collaborate with you guys if you have this kind of great ideas. I do have a strength in type 1 diabetes because my centers have 10,000 patients with type 1 diabetes that we care for, plus all these research studies in type 1 diabetes. So it's a humongous population, great amount of EMR-based data, plus the data that we are collecting now. So if you want to add something to that, I'm always happy to collaborate.
So in your one study where you had quite of a large age range, I think it was like 5 to 71 years of patients. Have you considered separating the data into like young, middle-aged, and in age to see if there's a difference, not only in BMD, but also with like fracture risk, to see if maybe by the time you have changes in bone, maybe the microvascular complications are contributing to what's happening in the skeleton?
Right. The design of this study was actually, we wanted to recruit the people across the lifespan, right? So that's why it was a design in a way that it's we included from 5 years to 71 years. And also it was by partially default because we included the patients from 3 ongoing studies. One of them was the CACTI study that I mentioned. Another one was the ROSE study that was including the children with type 1 diabetes. And the study was trying to understand the impact of a celiac disease on a bone health, but we excluded the people who have a celiac disease, and we just recruited only patients with type 1 diabetes here. So anyway, it was kind of a mix and match from all 3 studies, and you can see here that, and we kind of like looked them age to age wise. So we have a type 1 diabetes, we had a control group, and you can see the red line is type 1, the blue line is control, if I'm not wrong. No, I was wrong. Blue line is the type 1 diabetes and red line is the control. And you can see each dots here, right, at different age groups, or probably at any age, was not that different. And it's like a 1 standard deviation is considered as a normal, right? So to my mind, it wasn't that different. The only difference we found when we looked at is a postmenopausal women with type 1 diabetes compared to control. And the lower was at the femoral neck and total hip. Again, it was a statistically significant, but if you ask me clinically, it was probably not that clinically significant.
But this one this is the bone mineral density. Do you know what about fracture risk across?
No, we did not have that information. We had information about fracture risk only in one study, that's a CACTI study, but we did not have any information about fracture risk in the children and the young adults that were recruited from 2 different studies. Great question, but yeah, we did not have that. Also, we did not have any, information on their bone structural quality by PQCT or other imaging measures. But
Can I ask other
yep,
questions?
go ahead.
So you mentioned AGEs, and we don't really know exactly what are their effects, so like, what is your what do you think about them? How do you think that they would impact like bone health in diabetes?
So in my simple understanding, the glycation of collagen, this is a non-enzymatic glycation, right? And glycation happens with the curve is a linear curve. So the more the glucose, and so one thing that determines the glycation is the glucose amount, and the second is the duration of that glucose rise, right? So two things would determine the AGE generation, and that happens in almost kind of each organ, and and the cartilages and the bones have a lot of collagen. So I think these are the organs of interest when you want to look at the AGEs. So number one is that the people with diabetes, and this is true for both type 1 and type 2 diabetes, it won't be surprising that if you see a higher AGE contents in their bone, right? Because they are living with hyperglycemia. Even though they have a normal A1C, let's say, for example, ADA recommends, that's an American Diabetes Association, recommends then A1C of 7% or below for a good optimal control, right? But that's really not normal, because normal healthy volunteer would have an A1C of less than 5.7. So still, people who have a really excellent control are still hyperglycemic if you look at like a pathophysiological way or physiological way, right? So I would not be surprised to see more AGE contents in the bone. The question that I don't know really is that how long they get deposited there, how long they last. So let's say, for example, someone had a bad diabetes control. Now you have a more AGEs in deposition in the bone. But then after 5 or 10 years, something happened to your life and now you change totally, right? And now you have an excellent control. Would that deleterious effect of AGE that happened 10 years back would be reversed? Again, I don't know that part. Or it persists, I don't know that part. I think it's hard to study too, but and also the thing is that there are so many different kind of AGEs, and I'm not an expert in the AGEs. I think Dr. Vashist from Harvard, he is kind of an expert guy in this area, the collagen. But yeah, to my mind is that yes, we do understand that people with diabetes would have a higher AGE content in the bone, and probably serum as well. Again, I'm not really fascinated by the serum part, because serum would be changing faster than the bone. So serum will give you more of a cross-sectional idea, but the bone might give you a longitudinal idea. But that's again my thinking. And again, learning from the normal physiology of aging, we know that the AGE has a deleterious effect on bone. And so again, from those perspective, yes, AGE in diabetes are major culprit, but there are a lot of questions that I don't know that you are raising. It's all great questions, but yeah, I don't have an answer, unfortunately.
And another question that I apologize if I haven't really picked it up, because when you were explaining about like the design of the studies that you were starting, the RO1 and 2, how are you dealing with the microvascular complications in the studies? Like, I don't know if I missed the information or.
Yeah, it's because that I didn't highlight every single details there. So microvascular complication, we do have a very well validated measures. It's again questionnaire. So like, for example, we use this simple one questions that, okay, did you require any laser therapy or intraocular injections therapy for your eye complications? If the patient answer yes, then 99% of the time patient has retinopathy, right? So just one question. Then we are using Michigan instrument questionnaire for diabetic neuropathy, which is very well validated in DCCT, and that was used in DCCT clinical trial too. So yes, we are collecting the information of microvascular complication, but we are also collecting their back stories and forward stories. So that's what I tried to say, that we are collecting the 10 years of medical record and trying to understand their diabetes care for 10 years. And then these patients will be followed 3 years prospectively, where we are collecting that prospective information. So I think we are hoping that we will have a really good amount of information in R01. But yeah, I will tell you that in 2025.
So you are planning to maybe do like a subgroup analysis, maybe to see like people with microvascular complications and like if you get people without.
So of course we will try to do that, right? But I call them as an exploratory analysis. When you try to do a statistics which is not priori hypothesized and your sample size is not based on that hypothesis, it's all exploratory analysis. So sure, we all do that, but always take that with a pinch of salt, right? It's just a hypothesis generating, doesn't mean that it provides you good evidence, but it can help you to design your next study for sure.
So in general, do you see the microvascular complications occurring prior to changes in bone?
I don't know that part. Again, good question, and I don't know that part. And my answer is it should, yes, in general, because the hyperglycemia is one of the determinants of AGE and of course affecting the bone, some kind of like a direct hit, because hyperglycemia is going to lead to hypercalciuria. You're going to lose more bone. David Weber did really nice an experimental study. He looked at the kids who are poorly controlled, the kids who are probably better controlled, and he did a calcium tracing study, and he found that people who are poorly controlled had a more calcium excretion, which is again not surprising, but it's a good and experimental design. So now think about that. When he did the study, it was a cross-sectional way of looking at calcium excretion, right? But if there is an hyperglycemia keep going on for 5 to 10 years, you're gonna keep wasting that calcium for 10 years. So I think hyperglycemia per se may affect the bone health that is independent of AGE or some other things that we talked about. So in my thinking, yes, people can have probably adverse bone outcomes even without microvascular complication. But the risk is higher because microvascular complication tells you the story that it was not a good glycemic control for many years, right? So in those people, you're gonna probably have a more brittle bones.
Okay.
Would that also go to their fall risk too, though? Are you accounting for?
We did
fall
a
prevalence?
study and we looked at, so one thing is that when we think about the fall in a normal healthy individuals or probably older adults, it's the fall because of their gait and the musculoskeletal complications. But there is one more factor in people with type 1 diabetes, because everybody's on insulin, is the hypoglycemia. When you have a hypoglycemia, then you are at more risk of probably having a dizziness and you're going to fall, right? So when we looked at into the T1D exchange, the hypoglycemia, which is we defined as a severe hypoglycemia requiring a medical assistance or the assistance by your family member, was associated with 2.5 times increased fall risk in people with type 1 diabetes. And out of those falls, I think if I'm not wrong, 14% led to fracture. So yes,
Neuropathy contribute to that too, though, with that
the
they have
answer
the
is yes. Okay. Yeah. And again, neuropathy, it's indicative of two things. Number one is that microvascular complication, long-standing poor diabetes control, right? And number two is that now you're going to have a gait imbalance. You're not going to probably have a sensation. You're going to have a high risk of fall. So yeah. Interesting, complicated, right?
I know we're right at the top of the hour. So I
Okay.
want to thank everyone for joining. And it was a small group, but it was great discussion, very interesting presentation. So thank you all for joining. The series is going to be monthly. It'll take place monthly on the last Wednesday of every month at 1 p.m. And there should be an updated schedule on the ASBMR website soon. So we hope to see you guys next time. And again, thank you for joining.
Great,
Thank you, everyone.
Thanks for the presentation.
It was great, really great. Thank you.